Hi, this is Dr. Tim Conley at Yeshiva University, and I'd like to talk a little bit about a class of drugs called hallucinogens. It consists of several highly diverse classes of compounds. Most prominent effects from hallucinogens are alterations in perception, cognition, affect, sense of meaning, sense of self. Um, and there are a class to end with here are PCP and other drugs that are called dissociatives or dissociative anesthetics. They receive their own treatment in our textbook, but we can consider them in with the hallucinogen class of drugs because they're similar acting effect. Actually, the term hallucinogen is a bit of a misnomer. Most of the commonly used hallucinogens really cause true hallucinations. Hallucinations being seeing things that aren't there, hearing things that aren't there. It will change your perception and belief about things, but in terms of like, I'm seeing stuff, that doesn't really generally happen with these. The word psychomimetic has been used because many of these drugs will mimic a psychotic break. It's very difficult in an emergency room to determine if somebody is experiencing schizophrenia and delusions and paranoia, or if they're under the influence of a substance. In fact, in order to make the diagnoses of mental illness, a variety of mental illnesses, you have to rule out that it is not caused or exacerbated by use of the substance. And that's certainly true in psychiatric crisis cases. Are they mentally ill or are they high on something like, a psychedelic? Psychedelic is a term from the 60s. These substances, and certainly in American history, have a fairly colorful history, having been very popularized in the 1960s by research. Dr. Timothy Leary, formerly of Harvard, did a lot of research on this. They became part of a counterculture and a whole 60s thing that was going on, part of the anti-war movement that spawned terms like hippies and it really kind of worked its way into the culture as a, what was it? Tune in, turn on, and drop out, or turn on, tune in, and drop out kind of thing with substances that included your counterculture and subculture of hallucinogen users. Be sure to look in the textbook for this course at table 16.1 so you can see all of the substances that are used as well as their common street names, because you will encounter these, as we'll see in a minute, not real frequently, but when you do, it's good to know. LSD is called acid or bladder acid, that psilocybin's called mushrooms or magic mushrooms, just shrooms. DMT has a name. There's different street names, mescaline, peyote. So be familiar with those a little bit. Salvia has been showing up quite a bit lately. MDMA, ecstasy, Molly, MDA, love drug, et cetera, et cetera. So be familiar with some of that terminology. You'll find it useful. Yeah, the 60s, 10,000 subjects received hallucinogens, mostly LSD from the 50s to the 60s, to try to see what could be done with them. If most of the research focused on the effects of treatment of substance use disorders, believe it or not, let's treat one substance with another. That practice goes way back, including the belladonna treatment of even the 1930s that Bill Wilson underwent. There's some history that Wilson himself experimented or was experimented on with hallucinogens as a way to control severe cases of alcoholism. And they were used for treatment of pain and end-of-life disorders. There were a lot of promises on that research until it became illegal. The drugs were outlawed. Many drugs have been outlawed at different points in history. And at the same time that marijuana laws were getting a little ridiculous, so did the laws for these hallucinogens. All of the trials generally included very controlled clinical settings, psychotherapy before and after the administration of the substance, etc. So we'll talk about research again a little bit in a minute, I think. Hallucinogen use disorder is listed in your DSM-5. be sure to know the 10 of the 11 criteria can apply to this. Generally not withdrawal. You don't get withdrawal and withdrawal avoidance syndrome from using these, but definitely tolerance and all of the other salient effects that the use of the substance can have. You may find a history piece in the book interesting. The epidemiology will tell you that this is a very infrequently used drug, and it very infrequently presents for treatment. But it's just good to know a little bit about it when it does show up. It's almost always used concurrently with other substances. So you'll see a polysubstance use in which a person's using marijuana, drinking alcohol, and taking a hallucinogen of some sort on a fairly irregular basis, sometimes more regularly. It can lead to patterns of compulsive, harmful use, harmful and compulsive use, especially with MDMA. The hallucinogens vary with degrees, to varying degrees, like two important characteristics that I mentioned of addiction to drugs: the positive reinforcement and the negative reinforcement. Let's see where else we wanted to go with this. There has been more recent research done into the use of hallucinogens, pharmacologically produced laboratory hallucinogens that are produced and used in clinical trials, again, for the treatment of mental illness disorders. Severe depression can be impacted by use of hallucinogen. There's some evidence that used concurrently with an evidence-based practice like cognitive behavioral therapy, that hallucinogens may interrupt the course of alcoholism and other drug use disorder. I would say the jury's still out on that. Now, the practitioner's point of view. What have I seen? What do I see in the field of addictions as a clinical social worker treating populations presenting with substance use disorders? I haven't seen much good come of it. I've seen people who take a little bit of popular culture, the same way that they would say, hey, a little bit of wine is good for your circulatory system, and they drink 3 bottles a day. Not good for your circulatory system. I've heard that you can stop using methamphetamines if you use just take trips, take acid instead, and it'll interrupt it. Well, it may actually interrupt the course of methamphetamines, but you're still got issues. You still are not dealing with life on life's terms. So clinically, I look askance at it. Understand maybe there's some value there. Maybe there's some value to medical marijuana, etc. In the treatment clinics, I don't see it so much. I have to deal with the symptoms that are presenting, social, occupational, recreational impairment, inability to, conform in any degree to what individuals expect of themselves in life. They'll have a sense of what they want to be, how they want to be, what they want to do, and it won't be happening because of the substance use. I see that with hallucinogens as well as the other substances. Good. Be aware of these as well as any substance that's going to come across. Always look at them through the diagnostic lens. As clinicians, we want to look through the diagnostic lens of, is this impairing the person in life? Are they meeting criteria? And how are we going to best treat those?